All right, today we're going to talk about cirrhosis, but maybe not in the way you're used to. We're not just looking at it as a disease. Think of it more like a catastrophic systems failure. We're going to explore it through the lens of a critical piece of infrastructure in your body, the plumbing, and what happens when it completely and totally breaks down.
I mean, really think about it. Your liver is this amazing filter, right? A chemical processing plant working 24/7. But what happens when that filter gets so scarred up, so clogged, that it just can't do its job anymore? All that pressure has to go somewhere, and believe me, the consequences are devastating. So let's trace that pressure all the way back to its source.
So this whole cascade of awful problems, it all starts with one thing: a massive, dangerous buildup of pressure. And that, right there, is a condition called portal hypertension.
And to give you a sense of just how serious this is, the normal pressure in the portal vein, that's the main highway of blood going into the liver, is less than 6 millimeters of mercury. With portal hypertension, we're talking more than double that, often exceeding 10 or 12. It's literally like trying to force a fire hose worth of pressure through a tiny garden hose. This isn't some small tweak. It's a fundamental and super dangerous shift in your body's entire plumbing.
So why does this pressure spike happen? Well, when you break it down, it's kind of this perfect storm. It's a two-part problem. First, you got a physical blockage inside the liver from all the scar tissue. But then, and this is the crazy part, the body gets confused and actually sends more blood rushing towards that exact same blockage. A clog and a flood, all happening at the same time.
Okay, so how exactly does this clog even form? What's going on in there? Turns out it's not just one thing. It's a combination of both physical problems and, well, biological failures. Let's really dig into the anatomy of this clog. And when you actually look at what's causing all this resistance, the breakdown is pretty surprising. A whopping 70% of the problem is structural. I mean, the liver's actual architecture is physically warped and scarred. The other 30%? That's functional. The cells themselves are just not doing their job right.
The easiest way to think about it is like a computer. The structural stuff, the fibrosis, the scar tissue, that's a hardware problem. The physical parts are literally broken. But the functional changes, that's a software problem. The liver cells basically get a bad software update. They forget how to make nitric oxide, which is what helps blood vessels relax. And instead, they start listening to these other chemicals that tell them to squeeze tight, which, you guessed it, makes the blockage even worse.
So with all that pressure building up, the system is desperately trying to find a release valve. But here's the tragic part. The body's emergency solutions are often way more dangerous than the original problem. This pressure kicks off a deadly domino effect.
Okay, so the blood can't get through the liver, right? It's got to go somewhere. So it takes a detour. It forces its way into these smaller, much weaker veins, especially in the esophagus, and these veins just swell up. They're called varices. Think of them like varicose veins, but in the absolute worst possible place where they can burst and cause a massive, catastrophic bleed.
And you might be thinking this is some rare thing, but no. These incredibly dangerous varices, they show up in about half of all patients with cirrhosis. It's a terrifyingly common result of that out-of-control internal pressure. It just sets the stage for a total disaster.
And just how bad is that disaster? Well, when one of these varices bursts for the very first time, the mortality rate is a staggering 20 to 35%. Just let that sink in. You have up to a 1 in 3 chance of not surviving the first bleed. It's a medical emergency of the highest possible order.
But the pressure doesn't stop there. It doesn't just reroute blood. It also makes the blood vessels super leaky. The liver and all the vessels around it literally start weeping fluid right into the abdomen. This massive fluid buildup, that's what we call ascites, and it's another one of the classic terrible signs of advanced liver disease.
And the dominoes just keep on falling. This circulatory chaos eventually starts starving the kidneys of blood, which leads to this really unique kind of kidney failure. And at the same time, the spleen, which is plugged into this whole high-pressure system, gets totally engorged with backed-up blood and just swells up dramatically.
Now, this giant swollen spleen, it creates another huge problem. Normally, your spleen holds about 1/3 of your body's platelets, but when it's all swollen up from portal hypertension, it can start hoarding up to 90% of them. And without platelets, your blood can't clot, which, as you can imagine, makes the risk of bleeding from those varices even more catastrophic. Okay, so with this absolute cascade of failures, how on earth do doctors even begin to fight back? Well, they start by trying to manage the most immediate, life-threatening problems, and of course trying to get that dangerous pressure down. To stop those varices from ever bleeding in the first place, there are basically two main strategies. First up are medications, like propranolol. These are beta blockers, and they help lower the pressure in that whole portal system. The second approach is more direct. Doctors can actually go in with an endoscope and tie off the riskiest-looking varices with these tiny little rubber bands. It's a procedure called ligation.
But what if a bleed actually happens? Then it is all hands on deck. Step 1. Hit the patient with powerful drugs that constrict blood vessels in the area to try and reduce the flood of blood. Step 2. An emergency endoscopy to go in, find the bleeder, and stop it right at the source. And Step 3, which is absolutely crucial, give them antibiotics, because infections in this scenario are incredibly common and often deadly.
But sometimes the medications and the little endoscopic tricks just aren't enough. When that happens, doctors have to get way more aggressive. They need to physically reroute the body's plumbing to bypass that central blockage.
And this leads us to one of the most incredible procedures in modern medicine. It's called a transjugular intrahepatic portosystemic shunt, or TIPS for short. What is it? Essentially, it's a man-made bypass for the blood, and they build it right through the middle of the diseased liver itself.
So here's the nuts and bolts of it. An interventional radiologist threads this catheter through the jugular vein in your neck, guides it all the way down into the liver. Then, they create a brand new channel connecting the high-pressure portal vein to a low-pressure hepatic vein, and they prop it open with a metal stent. This new bypass immediately drops the pressure, taking a massive amount of strain off the entire system.
Okay, so with the disease this complex, with so many things going wrong, doctors need a quick way to figure out just how sick a patient is. They need to predict their chances of survival. To do that, they use these standardized scoring systems. Think of it like a clinical report card for the liver.
The two big ones you'll hear about are the Child-Pugh score and the MELD score. Child-Pugh is a bit older, and it includes some subjective things, like a doctor's assessment of how bad the ascites is. The MELD score, though, is totally objective. It only uses lab values, bilirubin, creatinine, INR. And because it's purely data-driven, MELD is the system we use here in the US to decide who's the sickest and who gets first in line for a liver transplant.
And look, all of this really just brings home a critical reality, one that the experts always emphasize. The mortality in this condition is just incredibly high without the absolute best management. This isn't something that can be handled casually. It demands specialized care and really precise timing for interventions.
And that really brings us to the big final question, doesn't it? We've walked through this brutal, predictable domino effect that all starts with that high pressure in the liver. So the real challenge isn't just treating the fallout once it happens, it's figuring out how we can detect that pressure buildup way earlier. Before that first deadly domino even starts to wobble.